Hello students, so now let's discuss about the second pharmacokinetic parameter, that is distribution. So after absorption, let's assume the drug has reached to the heart. So can we say now this heart will pump the drug to the whole body? So one basic question now comes in our mind. Sir, whether this drug will remain inside the blood vessel or it will move into the organs. Now remember, if this drug moves into its target organ where it must go, then the drug will produce its beneficial effect. Beneficial effect is known as therapeutic effect. But if this drug goes into unwanted organs, don't you think it will produce unwanted effect, which is known as adverse effect? Now, what is therapeutic effect? What is adverse effect? Because effect word is coming, we will discuss in pharmacodynamics. Here in pharmacokinetic, we have to check the movement of the drug. And here we determine whether the drug will move into the organs or not. And this movement of a drug from blood vessel into the organ is known as VD. VD stands for volume of distribution. It tells us about how much drug is entering into the organ. So let's understand volume of distribution. So first we will write 3 points and then we will understand. In one word, volume of distribution means extravascular deposition of a drug. That how much drug is moving into the organ. So extravascular deposition of a drug into organs. Second point, this volume is not a true volume. That means it is a false or apparent volume. Apparent means false. Apparent volume of plasma. Now beta, because this word apparent is coming, that is why volume of distribution, it is either known as VD, the symbol is VD, or some books writes AVD. A stands for apparent volume of distribution. Now let's write the definition. So volume of distribution is, it is the volume of plasma, and you write volume as liter or ml. Let me write ml. It is the volume of plasma required to contain a drug in equal concentration as that of plasma. Now, I hope you have not understood this definition. So first, let me make you understand, and then again we will come back to this slide. So sir, suppose this is plasma. And can we say that a 70 kg person, let's assume a person is 70 kg, and 70 kg person has in his body 4 liter of plasma. Now let's say I have given a drug A by IV route. Why IV? Because we don't want to discuss absorption right here. And IV drugs, they are directly entering into the blood. They are not crossing any cellular barrier. So there is no absorptive pathway in IV drug. So I have given a drug IV and whole of this drug enters into the plasma. Now, let's say this drug A does not move into the organ. That means 100% of the drug remains in the plasma. It does not move into the organ. So, can you tell me volume of plasma required to contain this drug will be? Yes, this drug is contained in 4 liter of plasma. So for this drug A, volume of distribution is 4 liter. This drug is present in 4 liter of plasma. Now let's take another drug to understand better. There is a drug B, and this drug also enters into the plasma. But this drug has a property that 50% of the drug remains in the plasma and rest 50% of the drug enters into the organ. So half drug remains in plasma, half moves into the organ. So can we say in 4 liter of plasma, only 50% of the drug is there and rest 50% is in organ. Now for a moment, assume that your organs are also made up of plasma. That means this plasma in red is the true plasma and this organ is a false plasma which we have assumed. So can you tell me that if 50% of the drug require 4 liter of plasma, another 50% of the drug will require how much plasma? Yes, another 50% of the drug will require 4 liter of plasma. That means 4 liter of true plasma and 4 liter of false plasma. So this drug is contained in total 8 liters of plasma. So the volume of plasma required to contain this drug will be 8 liters. Let me give you another example. Let's say there is a drug C. And this drug C has a property that only 25% of this drug remains in 4 liter of plasma. Rest 75% drug enters and deposits in organ. So let's assume these organs has false plasma or apparent plasma. So can you tell me if 25%, that is 1/4 of the drug is present in actual 4 liter of plasma, then 75% drug will require how much plasma? It will require 3 times plasma. So it will require 4 into 3, 12 liters of plasma, which we have assumed. So can you tell me the total amount of plasma this drug will require? So the total amount of plasma required to contain this drug will be 16 liters. Now if you have understood this pattern, just see this. As the volume of distribution is increasing, can we say more drug is entering into the plasma? Agreed? So let me get those 3 points back. So in one word, volume of distribution means extravascular deposition of a drug. Is it a true volume of plasma or false volume of plasma? It's a false volume of plasma, and see the definition now again. It is the volume of plasma required to contain a drug in equal concentration. So in simple word, if a drug is moving out of a blood vessel, getting deposited into the organ, it will have high volume of distribution. So how do we calculate this volume of distribution? So formula to calculate VD is very simple and logical. So volume of distribution is dose of a drug given, dose given with IV route divided by plasma concentration measured. Which plasma we are talking about? We are talking about actual plasma. Let's take an example. Sir, suppose if I have given 20 milligram of the drug and in plasma I am only finding 5 milligram per liter of the drug. This will be the concentration. Can you tell me the volume of distribution? That will be around 4 liters. Agreed? Let's say if I have given 20 milligram of the drug and in plasma I am only finding 2 milligram per liter. Can you tell me the volume of distribution? It will be 10 liters of plasma. Now this 10 liter of plasma means 4 liter actual plasma and 6 liter assumed plasma, because our body does not contain 10 liter of plasma. Okay. Now, what should be the units of volume of distribution? Units of volume is always and always liters. So you can express in liters or you can also express in ml. But beta, don't you think volume of plasma changes with body weight? A small child will have less volume. A big person, a heavyweight person will have higher volume of plasma. So it's better to express volume of distribution as liters per kg of body weight. So if you divide by body weight, it becomes equal across all age groups. Okay. So now this pattern you can see very easily that if you are finding a drug in less concentration in plasma, so as plasma concentration is getting reduced, volume of distribution is getting increased. So that means the drug is moving out of a blood vessel. So this is volume of distribution. Now let's talk about on what factors volume of distribution depends. So the first factor which modifies volume of distribution are drug factors, the properties of drug. And the first property of a drug we will write is lipid solubility of a drug. Now it's very simple. Suppose beta this is plasma and this drug is a lipid soluble. What do you think this lipid soluble drug will love to remain in a watery media like plasma, or it will move out of a blood vessel and deposit in organs like fats? So lipid soluble drug would love to deposit in fats. So can we say more drug will move outside? So hence lipid solubility is directly proportional to volume of distribution. That means higher lipid solubility, more drug will go into the tissues, so its volume of distribution increases. And we discussed in absorption part that lipid solubility depends upon pK value of a drug. Now the second property is plasma protein binding. Plasma protein binding of a drug. Now, beta, in our plasma, we have big plasma proteins like albumin, etc. So, if this drug is attached to plasma protein, PP, do you think these plasma protein will allow a drug to move outside? The answer is no. The drug will not move outside. Hence, plasma protein binding, if there is more plasma protein binding, it will decrease volume of distribution. So plasma protein binding is inversely related to volume of distribution. So now one question came, and try to answer this question. There is a drug known as warfarin. Warfarin is highly lipid soluble. It is highly lipid soluble and it is 99% plasma protein bound. I am just writing the word protein. Which protein bound? Albumin bound. That means it is highly lipid soluble. It has high plasma protein binding. So what will be the volume of distribution of warfarin? Will it be having high volume of distribution or will it be having low volume of distribution? Now, why this question has been asked? Because if a drug is both lipid soluble and highly plasma protein bound, which factor will dominate or which factor is the main determining factor? It is always and always plasma protein binding. It is the predominant factor. The reason is very simple. Even if a drug is lipid soluble or water soluble, we don't care. If a drug gets attached to plasma protein, any type of drug, plasma protein will not allow a drug to move outside. So plasma protein binding is the main factor that determines the volume of distribution. Now, second factor we will write is patient's factor or physiological factors. How the body is there, physiological or patient's factor. So, volume of distribution depends upon age, gender, and pregnancy. So, any drug volume of distribution changes with age, gender, and pregnancy. The reason is very simple. In small child and a young adult, we have more plasma protein. In old age, the amount of plasma protein reduces. Similarly, males, they have more plasma protein. Females, they have less plasma protein, more body fat. Similarly, the amount of plasma protein changes in pregnancy also. So, if plasma protein binding changes, the volume of distribution will change. Less plasma protein, more drug will move outside the body. Similarly, certain pathological factors like diseases. Can you think about that which organ makes this plasma protein like albumin? Yes, that is liver. So, in case of liver disease, beta, what will happen? There will be decrease in plasma protein synthesis, that is albumin synthesis. So, albumin production is less in liver disease. Can we say less albumin means less plasma protein binding? Less plasma protein binding means there will be increase in volume of distribution. And if a drug has a higher volume of distribution, it might enter into unwanted organ. And if it is entering into unwanted organ, it might produce toxicity. That is why we reduce the dose of a drug in liver failure. Another point is kidney disease. Now, in kidney disease, the hallmark of kidney disease is the albumin gets lost out in urine, which is albuminuria. Again, the plasma protein levels will reduce because albumin is getting lost in urine. The drug will remain more amount in free form, not in bound form. Increase volume of distribution, increase toxicity. Similarly, this composition of plasma and plasma protein, it changes with conditions like hemorrhage, blood loss. In burns patient, the plasma and proteins, they leak out of the blood vessel, and in shock also. So in burns and shock, the blood vessel becomes leaky. Plasma and protein gets leaked out of a blood vessel. If a drug is attached to plasma protein, the drug will also leak out of a blood vessel. More drug will enter into unwanted organ. Again and again, the toxicity of a drug may arise in these conditions. Hence, we give a little bit lesser dose of drugs in burns, hemorrhage, shock like condition. So these are the factors which modify VD, and the main factor is plasma protein binding. So keeping this thing in mind, let's talk about the plasma proteins. So in our blood or plasma, we have predominantly two types of plasma proteins. The first plasma protein is albumin, and second is alpha 1 acid glycoprotein. Okay. Now in albumin, you are finding B word. So albumin is a basic plasma protein or basic protein. Hence albumin binds to acidic drugs in blood. It binds to acidic drugs. Now in alpha 1 acid glycoprotein, you can see a word acid is coming. So it is obviously an acidic plasma protein, and hence it will attach to which kind of drug? It will bind to basic drugs in our blood. It will bind to basic drugs. Okay. So let's write the list of acidic drugs and basic drugs which are attached to these respective protein. So albumin is a basic plasma protein and it attaches to acidic drug. And the name of acidic drugs we can write with the help of a mnemonic: acidic, all acid bind with albumin strongly. So A for aspirin, which is under a class of NSAIDs, non-steroidal anti-inflammatory drug. NSAIDs are acidic drug. Then barbiturates, anti-epileptic drug like phenytoin, valproic acid, they all are acidic drug. Barbiturates like phenobarbital, warfarin, acetaminophen, which is also known as paracetamol, and sulfonamide and sulfonylurea. Sulfonamides are antibiotic. Sulfonylurea are drug for diabetes, which causes insulin release. Now, in alpha 1 acid glycoprotein, which is an acidic protein, it binds to basic drug. So the mnemonic is ABC, oil. So remember, any drug acting on heart, used in heart condition, will be a basic drug. Okay. So anti-arrhythmic drugs, beta blockers like propranolol, they act on heart. Calcium channel blockers like verapamil, they also act on heart. Opioids like morphine given for MI patients. Imipramine, just remember it is a TCA, tricyclic antidepressant. And lignocaine, local anesthetic and given for arrhythmia. So these are the drugs, just write for your reference. Now the question which is asked is a very important and pertinent question. What is the importance of this plasma protein binding? So please write one concept first and then we will discuss in detail. That plasma protein binding of a drug is non-specific, and reversible. Now what does it mean? Two words, non-specific and reversible. Suppose this is a plasma protein, albumin or any other plasma protein. So where does a drug bind? Remember, drug can bind to any site. So the site is non-specific. So drug can attach to any site. There is no specific site. And the binding of a drug is reversible. Now, because the binding of a drug is reversible, if I give another drug, let's say drug B, don't you think this drug B can displace this drug A? So this drug A will become free. So because of this reversible nature, displacement of a drug by another drug can occur. So drug displacement can occur. And don't you think if this drug A is free, it can move into unwanted organs? And in unwanted organs, it can lead to unwanted effect like toxic effect. So let's understand with very important examples which are important in our patient. So the first example of this drug displacement is so drug displacement from plasma protein. We will discuss three examples. The first example is all anti-epileptic drugs, they increase each other toxicity. How? Let's say there are many anti-epileptic drugs like phenytoin given for seizures or epilepsy, valproic acid. I will just write three, phenobarbital, but you can also write others also. Now let's say there is a patient who is taking phenytoin, and we know anti-epileptic drugs are attached to albumin, and let's say patient is taking phenytoin. Now because of some reason the seizures are not getting controlled. So as a doctor you decided to add one more anti-epileptic drug, valproate. Let's say you have decided to add it valproate. Now as you add valproate, can we say valproate can also bind to same site? It is also an acidic drug. Because of this reason, this phenytoin will become free. And the plasma protein binding of phenytoin will get reduced. That means now it is free, its volume of distribution will increase, it will enter into the unwanted organs, and phenytoin can lead to toxicity. So now see the definition again. All anti-epileptic drugs increase each other toxicity. We will write the reason in word format. That reason is they displace each other. They displace each other from albumin. Because of this reason, the free fraction of a drug increases. If free fraction of the drug will increase, the volume of distribution will increase and the drug will enter into unwanted organs. Hence, it can lead to harmful effect, toxicity. Now, another question which is a very frequently asked question, there is an antibiotic known as sulfonamide, which is also available as cotrimoxazole. So this antibiotic is contraindicated in newborn infant or neonates, and it is also contraindicated in last trimester of pregnancy. Now let's see the reason for it. Reason we will write that these sulfonamides, they displace one molecule known as bilirubin. They displace bilirubin in our body is an endogenous toxin. It is a very harmful molecule produced after degradation of heat from albumin. So bilirubin is also attached to albumin because bilirubin is also acidic. Now this bilirubin will become free. So let's understand this part. So with albumin in the body, bilirubin is attached. B for bilirubin. Let's say you have started sulfonamide. Sulfonamide can also attach to same site. So this bilirubin will become free. Free bilirubin can enter into the organs. Now in an adult, bilirubin cannot enter into the brain. Why? Because the blood-brain barrier is fully formed. But in a neonate, it can enter into the brain of neonate. Because in a newborn child, the blood-brain barrier is not formed properly, fully it is not formed. And this bilirubin is a highly dangerous molecule. And if it enters into the brain, can we say it can lead to neuronal damage? So it can damage CNS neurons of neonate. So can we call it as encephalopathy? The brain will get damaged. And this encephalopathy, because of bilirubin in a neonate, it is also known as kernicterus. It is also known as kernicterus. And it's a very dangerous condition. So that is why sulfonamide antibiotic should be avoided in neonate and also last trimester of pregnancy when the fetus is fully formed. Because it displaces bilirubin, bilirubin enters into underdeveloped blood-brain barrier. Through underdeveloped blood-brain barrier, it enters into the brain and cause kernicterus. And the last interaction which is asked is aspirin causes hypoglycemia with tolbutamide. Now, tolbutamide is a sulfonylurea. So, what happens when you give aspirin? Aspirin displaces tolbutamide from albumin. So, again, tolbutamide free fraction will increase. And if this tolbutamide increases free, it will go into the organs. Its volume of distribution will increase. And tolbutamide enters into pancreas. And in beta cells of pancreas, the action of tolbutamide and sulfonylurea is to promote insulin release. So these are the drugs for diabetes which causes insulin release. Insulin release will lead to hypoglycemia. So now more tolbutamide will enter into the pancreas. So it leads to hypoglycemia. Now another importance of volume of distribution apart from drug displacement reaction is hemodialysis. So let's talk about hemodialysis. But a hemodialysis we generally employ in the treatment of poisoning of a drug. So if a person has taken very high dose of a drug, we employ hemodialysis. What we do in hemodialysis, we take out the blood of the patient outside. We take out the blood of the patient outside. And the drug which is present in the blood, it is filtered through a semi-permeable membrane. It is filtered outside so that this poison or a drug can be removed out of the body. So we take out the blood of the patient outside. Now the first question, think logically and answer that if a drug is having high volume of distribution, high VD drugs, in high VD drugs, there is no role of hemodialysis. HD is hemodialysis. Can you tell me the reason for it? High volume of distribution means high VD drug means that these drugs are not present in blood. They are not present in plasma. They are rather deposited in the organs. So why you are taking the blood of the patient outside and filtering it? The drug will not be in the blood because high VD drugs are not in plasma. So there is no point of taking blood outside and doing hemodialysis. So let me give you an example of high VD drug, that is digoxin. Digoxin volume of distribution is 450 liters of plasma. Such a high volume of distribution. So there is no role of hemodialysis in digoxin poisoning. Chalo, let's take another example now. Let's say the drug has low volume of distribution. That means the drug is present in plasma, but the drug is having very high plasma protein binding. Now, what do you think? If a drug is highly protein bound, will this protein will allow a drug to filter? Will they allow to cross a cell membrane? The answer is no. So again, If a drug is highly protein bound, there is no role of hemodialysis in the poisoning of that drug because plasma protein will not allow filtration of a drug. So a classical example is warfarin. So in warfarin poisoning, we don't do hemodialysis because warfarin is 99% albumin bound. Similarly, we will write one more drug, one calcium channel blocker, verapamil. Same reason, verapamil is highly protein bound drug. So question comes, finally, in which poisoning we should do hemodialysis? So we do hemodialysis in low VD drugs. Low VD means the drug is present in plasma with low plasma protein binding. That means the drug is present in plasma, which is a good thing. And low plasma protein binding means the drug is in free form. The drug is not in bound form and free form of a drug can filter. So in this case only we do hemodialysis. Okay. So let's write the list of the drugs in which we will do hemodialysis and those drugs in which there is no role of hemodialysis. So the poisoning of those drugs in which we do hemodialysis, mnemonic is blast. B for barbiturates, and you will find an MCQ with phenobarbital. L for lithium, A for alcohols, A for aspirin, and salicylates, and lastly, a drug for asthma, theophylline. So in the poisoning of these drugs, we do hemodialysis. No role of hemodialysis, we will write avoid ABC. A for amphetamine poisoning. V for verapamil and warfarin. We discussed the reason also. Organophosphate poisoning. Highly lipid soluble drug, very high volume of distribution. So organophosphate poisoning. Imipramine. Now imipramine is a TCA, which is tricyclic antidepressant poisoning. Because these drugs are attached in brain, they are not in blood or plasma. Digoxin, most commonly asked question. Amiodarone, antiarrhythmic drug. Benzodiazepine, the younger brother of barbiturates. Let's write one drug, diazepam for it. And lastly, one anti-malarial drug, chloroquine. And most commonly, you will find the question with warfarin, digoxin, and benzodiazepine. Okay. Now, among all known drugs, which drug has highest volume of distribution? The answer is chloroquine. Okay. So chloroquine among all known drugs to us has highest volume of distribution. Anti-malarial drug. It has highest volume of distribution, which is around 15,000 liters of plasma. So, do you think you have 15,000 liter of plasma? Obviously no. High volume of distribution means this drug is not present in blood. Almost whole amount of chloroquine when we take gets deposited in all organs. So chloroquine High VD means it deposits in various organs. That is what high volume of distribution means. Now, when chloroquine deposits in retina, what happens? In retina, chloroquine deposits like this concentric rings. It deposits like this concentric rings. So you can see this image of chloroquine deposition like concentric rings. Now, don't you think it is looking like a shooting board in which we shoot by gun or archery? This shooting board, which you see in sports, is also known as bullseye. Shooting board is also known as bullseye. That is why when chloroquine deposits in retina, it causes bullseye retinopathy. So this bullseye retinopathy causes permanent blindness. Right? Now, this is about hemodialysis. Now let's finish this distribution by a similar name known as redistribution. And remember, whenever the word redistribution comes, don't forget the name of a drug known as thiopentone. So whenever the word redistribution comes, don't forget the name of a drug, thiopentone. There are other drugs also which can show redistribution. So you can write fentanyl and general anesthetics. But what we have to remember is thiopentone. So let's understand what do you mean by redistribution. So first I'll make you understand and then we will write. So redistribution, it is seen with highly lipid soluble drugs. So which drugs show redistribution? Highly lipid soluble drugs. And these highly lipid soluble drugs, their main site of action is brain. So their main target is or main site of action is brain. So that is why thiopentone is an anesthetic agent. When we give thiopentone, patient becomes unconscious. Similarly, fentanyl also used in anesthesia and pain relief. Now, let's say you have given thiopentone into a blood. Can you tell me which organ has more blood supply? Is it brain or is it fats? Obviously, it is brain. Brain is a highly perfused organ. So, as you have given thiopentone into blood, because brain receives more blood supply, first thiopentone will enter into the brain. And as it enters into the brain, the person will become unconscious. So within 2 to 5 minutes, the person becomes unconscious. That is why it is known as anesthetic agent. Now this thiopentone from brain, now it will come outside, again into the blood. Now beta, what happens with most of the drugs? Most of the drugs, they are eliminated in urine. And when they are eliminated in urine, their action is over. But this concept, in case of thiopentone, there is something else. Thiopentone is a highly lipid soluble drug. Instead of going into the urine, thiopentone rather enters and deposited into fats. So it rather deposit into fats, and this process is known as redistribution. So instead of going into the urine, it rather redistribute into fat. So can we say because of this reason, its plasma concentration will fall? Now in plasma, the amount of thiopentone is very less. And because of this reason, the action of thiopentone on brain is over and the person will wake up now. Hence, the main site of action of these drugs are brain. After that, these drugs are redistributed or deposit into fats. Because of this reason, their action on brain is over. Okay, their action on the brain is over. So now you will find two questions on redistribution. First question, redistribution is seen with which drug? Thiopentone. Second question is, the action of thiopentone is terminated by or gets over by A, redistribution into fats. Okay, redistribution into fats or elimination into urine. What is your answer? So, redistribution of fat terminates the action of thiopentone. But rest all other drugs, their action is over by elimination into the urine. But with thiopentone, it is because of distribution into fats. So this is all about distribution, volume of distribution, and redistribution. Thank you very much.